Good evening, everybody. It's 8 p.m. and I think it's high time we start. I'd like to welcome us once again to today's meeting, which is one of our monthly end of the month meetings for the Nigerian Society of Colorectal Disorder. Today we have a special topic titled ERAS and colorectal surgery in a Nigerian setting. And our speaker is Dr. Abubakar Gagarawa. He's the Chief Consultant General and Laparoscopic Surgeon for the Department of Surgery. He's also doubles as the CMD of Ibadan University Hospital Okada. He's also of National Hospital Abuja. We are grateful for him accepting our invitation, and we look forward to his presentation. Again, as usual, we would entertain questions and comments and at the end of the presentation. And our Chief Rapporteur, Professor Emmanuel Gwari, I think I saw him just a minute ago online, will help anchor that session. And as usual, this is being recorded and will be accessed and will be available on demand at the end of the presentation. So without further ado, I'd like to invite and hand over the platform to our speaker for the presentation. Thank you, sir.
Hello, good evening, colleagues. I hope I'm audible.
Yes, sir.
Thank you so much. As has already been introduced, my name is Dr. Abubakar Gagarawa. I'm a general surgeon and a laparoscopic surgeon. I am highly honored to be invited to speak in this important platform. When I was invited and I reviewed your past presentations, I felt more honored because I saw a lot of my teachers and respected colleagues have presented before me. Particularly, I'm most grateful that I'm invited to speak after Mr. Jimmy Coker was invited. I respect him so much when it comes to spreading surgical knowledge in Nigeria and Africa. And I would like to say clearly that he was the person who taught me how to perform step-foot hemorrhoidopexy. That was 2011. So thank you so much. And I hope we would all continue to spread the knowledge and the skills. Now, this topic is ERAS and colorectal surgery in the Nigerian setting. And it is very important because ERAS is a form of scientific evidence-based perioperative surgical care that aims to get good outcome and prevents complications and mortality. Hello?
Yes, sir, we can hear you, sir.
You're audible, sir.
Okay. Now, this is our outline for today's discussion. We're going to introduce what ERAS is and give some short historical background. And we would highlight the perioperative care of colorectal surgical patients and see what is the ERAS recommendation as regards the perioperative surgical care of colorectal patients, and see what we have in Nigeria, then we'll conclude. We had already said that the perioperative surgical care is a continuum of clinical interaction between the surgical team and the patient during the preoperative, intraoperative, and postoperative periods. And the general aim of such interactions is a good surgical outcome. Now, on the other side, ERAS is an evidence-based, multidisciplinary perioperative care with the full aim of improving patient outcomes and reducing complications after surgery. It is an acronym for Enhanced Recovery After Surgery. And the first ERAS guideline was on colorectal surgery. So this discussion is very apt. Now we have ERAS guidelines covering so many fields: trauma, orthopedic, pancreatic, hepatobiliary, gynae, and so many other areas. And as at the time it was first published in 2005, the ERAS Society was not formed. It was formed by Professor Ken Ferron and Professor Ole Ljungqvist in 2010. However, registration only took place in 2012 in Stockholm, Sweden. Since it was registered, ERAS has completely expanded to all parts of the world because of its demonstrable good outcome on surgical patients. So now we have the Latin American group, we have various groups in Asia and other parts of Europe. Since it was first established, and since the first guideline in 2005, four more guidelines have been developed and published in colorectal surgery. And the last one was June 2025 in the World Journal of Surgery. Now, ERAS itself is now well rooted in the activity of ISS, that is International Surgical Society, and ISMEN, International Association for Surgical Metabolism and Nutrition. I have been a member of the International Society for Surgical Metabolism and Nutrition since 2011, and also a member of the International Society of Surgery. Do you hear me?
Yes, we can hear you, sir.
Okay, I had somebody calling my name. That's what I thought maybe. Okay, so the general scope of ERAS is that it is evidence-based, and the scientific process involves reviews of meta-analysis, randomized controlled trials, and other relevant studies. It is multidisciplinary, like the current review of colorectal surgery ERAS guideline was done by 18 people. 7 were colorectal surgeons, 5 were anesthetists. There was a urologist among them, even a pediatric surgeon, you know, and there were 5 anesthetists, as I said. So it's multidisciplinary. And currently it is specialty specific. Like, as I said earlier, we have the orthopedic group, we have the upper GI, hepatopancreatic group, and many gynae, and many other ones. Recently, they have formed the group for the low and the middle income countries. Unfortunately, I didn't see representation from Nigeria when I reviewed the membership. So it is dynamic, which means as more evidence appear, the recommendation or the recommendations change. So the recommendations are fueled by knowledge, and they pass through rigorous process. They have various ways they classify the strength of their recommendation, but the most standard one is whether it is strong or weak. When we say it is strong, it means the effects of the intervention being considered is very clear. It may be clearly in favor or clearly out of favor. So the desirable effects of the intervention, if it clearly outweighs the undesirable effect, we say that evidence is strong. But if there are trade-offs and uncertainty, then it is weak. The level of evidence, that is the quality of evidence, is further graded into high, moderate, low, and very low. When we say the level of evidence is high or the quality is high, it means that further research is very unlikely to change the confidence in the estimate of the effect. If it is moderate, it means further research is likely to have an important impact on confidence in the estimate of effect and may change the estimate. So when we say it is low, it means further research is very likely to have an important impact on the confidence, and the estimate of the effect is likely to change. Very low, it means any estimate of effect is very uncertain. What is the importance of the ERAS recommendations? When they are followed, they are determinant of good clinical outcome. They reduce mortality, early recovery, decrease length of stay, and decrease cost of care, and generate overall patient satisfaction. Because everything is standardized, it allows for modular training, modular surgical training, which is the current trend in surgical training, putting behind the health stadium method. Standardized care facilitates surgical research, and as I said earlier, it improves patient satisfaction. And the key components in the process is establishment of clinical rapport, information and communication dissemination between the surgical care team and the patient, and then documentation. There is also another fourth part, which is very important, adherence to surgical ethics. When we take surgical history in colorectal patients, our aim is to make diagnosis and identify any comorbidities that would affect the surgical care. And this is the normal way we follow. And we can see that all this, when added up, would give us the intended aim of making our diagnosis, and would help us identify any comorbidity and lifestyle that may impact positively or negatively on the patient care. When we examine surgical patients, the aim is to complement our history taking, and the aim is the same. Now, in examination of colorectal patients, the examination of the abdomen is central, and it follows the inspection, palpation, percussion, and auscultation. Regional nodes and intra-abdominal nodes are also assessed, and pelvic examination, either through digital rectal examination or vaginal examination, is also done, which may be done under anesthesia. Experts review other than the colorectal surgeons may also be sought, such as gynecologist, urologist, and so on. Whenever we examine patients, we shouldn't forget to appreciate them. And we do the examination as well, which is then it would be followed by investigation of the patient. Our aim is to establish the diagnosis, to identify comorbidities, and to prepare the patient for anesthesia, which in most instances is the general anesthesia. So these are the basic and some of the specific staging investigations we do. The PET scan is not very available in our region. I think it is only available now in Lagos. Hello?
Please go ahead, sir.
All right. So after confirming our diagnosis, these are some of the things we do in the preoperative preparation. All these, we would find out later that they have specific recommendations from the ERAS Society. We have to review the history, take examination, investigation, and review everything. We communicate what we have found with the patient and tell them our plan for further management. We document everything and get consent for any intervention we want to do. The ERAS management is a multidisciplinary, and we get all the people involved, from the nurses to the anesthetist to the gastroenterologist and clinical psychologist and the surgeon. Comorbidities and at-risk patients are identified. Optimization is done, which in most instances include anemia and blood consideration, anemia correction and blood consideration. Then we do the consider DVT prophylaxis, antibiotic prophylaxis, mechanical bowel preparation, fasting, carbohydrate loading. And in emergency situation, we have to resuscitate the patient and review our resuscitation before taking the patient to the theater. So intraoperative considerations, we have to confirm the patient and do our safety checklist, consider the various options for anesthesia, various options for positioning of the patient, and sterilization of the surgical pills, driving, decide on the access, whether minimal access or open surgery. And when we go in, whichever way we select, we confirm the pathology and do our procedure, establish hemostasis, consider drain, and close. This is what we do. So post-operative surgical care include recovery from anesthesia, fluid and electrolytes maintenance or management, nutritional needs, temperature regulations, which I would have started from intra-op, pain management, antibiotic management, early mobilization, prevention of complications, use of catheter, use of NG2, thromboprophylaxis, and then management of complications. So these are the summary points that all colorectal patients pass through. The post-operative complications could be general or specific. They could be early, intermediate, or late. And there are specific recommendations to prevent them or to manage them. So now let's go to the ERAS recommendation in colorectal surgery. We have already outlined the steps pre-op, intra-op, and post-op. The ERAS has 23 parameters that it has made specific recommendations. 10 are in the pre-op period, 5 are in the intra-op, and 8 are in the post-op period. This is based on the 2025 recommendation. So we have total of 23 parameters, but the second recommendation was subdivided into 6 groups. Now, this is the pre-op recommendations, parameters that were considered by the ERAS Society. We have one, the education and the information of patient. And then we have optimization, nutritional support during the pre-op period, post-operative nausea and vomiting prophylaxis, and pre-anesthetic sedation and anxiolytics, thromboprophylaxis rather, and mechanical bowel preparation, fasting and carbohydrate load, antibiotics and skin preparation, and pre-operative fluids. So all these ones have their own recommendations, and it is always important that we should stick to the recommendations that are given. It is highly recommended that patients should be educated about their diagnosis and about planned intervention. And information should be given in written form and well documented in the system that it was given, discussed, and understood by the patient. Now, let's go to the optimization. We'll come back to the others, which is nutrition and others. The optimization of the patient involves identification of high-risk patients. This is highly recommended. And there are various procedures for identification of high-risk patients. Most of the impacting parameters are related to cardiorespiratory risk for DVT, and risks related to difficult in access, such as obesity and alcohol. There are issues related to alcohol cessation, smoking cessation, and rehabilitation. Identification of anemia and its management. Now, the management of comorbidities is related to identification of patients with the cardiac problems, such as ischemia, and making sure that there is control of the cardiac output and the ejection fraction before taking patient for surgery. Also, patients with the respiratory problems, such as chronic obstructive airway disease and chronic asthma, the patients need to be referred to the physician for optimization, which may involve chest physiotherapy, nebulization, and other interventions. Patients need to stop alcohol at least 4 weeks. It is highly recommended that they should stop alcohol for elective colorectal operation at least 4 weeks before the surgery. And the same thing for smoking. The rehabilitation involves physical exercise, but it can also involve mental and psychological improvement in the correct group. While anemia management is very important, because blood transfusion produces poor outcome in colorectal surgeries. So it is advisable that anemia should be managed to prevent intraoperative transfusion during colorectal surgeries. Intravenous iron is recommended more than oral iron. And if there is no time for surgery, erythropoietin can also be used. Now let's go back to the nutritional support. Patients at risk of nutritional deficiency should be identified before going for major elective colorectal surgeries. And one form or another of nutritional support should be instituted at least 7 to 10 days before taking the patient to theater. The oral route is preferred more than the enteral route, which is preferred more than the parenteral route. The target is to make sure that the patient gets at least 25 kilocal per kilogram per day, and 1.5 to 2.5 grams per kilogram per day of protein during the nutritional rehabilitation. The post-operative nausea and vomiting prophylaxis is also very important, because it is an important cause of patient non-satisfaction, and it may increase the length of the patient's stay in the hospital and increase the cost. It may also be associated with some complications, such as wound complications. So post-operative nausea and vomiting should be anticipated, and the appropriate prophylaxis instituted. This is very important in patients being planned for laparoscopic procedures. And they can be started preemptively on granistrone or on destrone, or sometimes even on steroids, especially in gravid patients going for laparoscopic pelvic surgery. The pre-anesthetic sedation and anxiolytics. Current evidence is not in favor of pre-anesthetic sedation and anxiolytics, and the recommendation is very weak or uncertain. For thromboprophylaxis, which is thromboprophylaxis, the recommendation is patient has to be assessed and placed at the appropriate risk group. It is based on that decision would be made whether you should go with the pharmacothrombophylacsis prophylaxis, or the patient would go with mechanical thromboprophylaxis, or both. For patients at high risk, the intermittent pneumatic compression is very important and has to be continued until when the patient starts moving, in addition to the pharmacological therapy, which could be either with the fractionated or with the unfractionated heparin. Mechanical bowel preparation is currently not recommended for colonic surgery. It is weakly recommended for rectal surgery if stoma is being considered, which means for both the colonic and the rectal surgery, mechanical bowel preparation is not strongly recommended. It's the same thing with the enema or rectal washout. But if mechanical bowel preparation is done, it is recommended that oral antibiotics should be used in addition to the intravenous antibiotics. Now, prolonged fasting is now not recommended, and the recommended short fasting is 6 hours of full fasting and 2 hours of total. Within the 6 hours, the first 4 hours, the patient can take clear liquids. Absolute fasting is only during the last 2 hours, and this is what is recommended. Carbohydrate loading has not been found to increase any patient outcome. The recommended skin preparation agent is chlorhexidine, which is found to be more than the povidone iodine. And skin hair removal is not recommended, but if it is done, it is better to clip the hair rather than to shave. Pre-operative disinfectant bathing has not been found to improve any outcome. Patient is encouraged to be fully hydrated before surgery. So clear fluid can be encouraged orally until 2 hours before being taken to the theater. But if there is any deficit, patient should be resuscitated and dehydration corrected before taking the patient to the theater. The intraoperative recommendations, we have the anesthetic protocol, the pneumothermia, the intraoperative fluid considerations, surgical approach, and the abdominal drainage, issue of abdominal drainage. It is highly recommended that patients should have a balanced anesthesia with short-acting agents. And anti-adrenergic and anti-inflammatory agents should be used to reduce the surgical response to trauma and surgery. Protective ventilation should be used throughout, and as much as possible, emetic agents should be controlled. So patients should be fully reversed and confirmed to have been fully reversed by use of muscle studies post-operatively, if available. Throughout the anesthesia period, the patient should be monitored for cerebral function to prevent awareness during operation and also to prevent any delirium during recovery. It is important to maintain good temperature control by using active body surface warming. This reduces the need for blood transfusion, and also it reduces clotting, intraoperative clotting anomalies and acidosis. The target for the intraoperative fluid recommendation is slight positive balance. Near zero balance, which used to be the recommendation, is now frowned at, and it makes the patient at risk of acute kidney injury, fluid deficit, and in some instances, it may also lead to cardiac failure. Now, the recommended surgical approach now for colorectal surgery is minimally invasive surgery or minimal access surgery. It has the same outcome as open surgery, but has a shorter hospital stay and more patient satisfaction and sometimes even surgical team satisfaction. The robotic approach for the minimal access surgery has not been found to have more advantage than the normal laparoscopic approach, and it is more expensive. So it's not the superior recommendation. Abdominal drainage may be recommended for rectal surgery, but it's not recommended for colonic surgery. For post-operative management, nasogastric tube increases the risk of respiratory tract infection, and but it decreases the chances of nausea and vomiting. It is, however, not recommended because it reduces return to early feeding and may increase other adverse outcomes like thromboembolism and by decreasing early mobilization. So for the fluids, we said it should be positive balance, and balanced fluid crystalloids should be used, not salt solutions like normal saline. The urinary drainage in minimal access surgery, colonic, within 24 hours, but if it is rectal, within 48 hours. Leaving the catheter longer than necessary, immobilize the patient and put the patient at risk of infections. And when there is prolonged immobilization, thromboembolism is also another major risk factor, and it increases length of stay in the hospital. Multimodal measures should be used to prevent ERAS. And nutritional support is also recommended during the post-op period. If it is identified in the pre-op that the patient needs, it should be continued within the post-op. So early mobilization should be within 6 hours. The aggressive early mobilization, which starts 30 minutes after recovery from anesthesia, has not been found to have any effect. And the aggressive in terms of duration, which used to recommend 6 hours per day, is also not found to have any major benefits. So within 6 hours, the patient can start moving and move as tolerated. Now, let's talk about the ERAS and colorectal surgery in Nigeria. This, I took one slide from Mr. Jimmy Cocker's presentation, which identified the problems in relation to his lecture on ulcerative colitis and Crohn's disease. It's still the same thing with all colorectal diseases and probably with all surgical diseases. He identified late presentation, delay in getting the surgery, more surgeries were done as emergencies, so they get more stomas in his own decision. So there was limited availability of advanced colorectal procedures. I brought this in to compare with what I have also found with the ERAS surgery. There is limited awareness, even among general surgeons. Probably only the specific colorectal surgeons, are aware of all the protocols. And even among most of the general surgeons, there is lack of strict specialization. I'm aware that most of the colleges, the National Postgraduate Medical College and the West African College of Surgeons, are trying to emphasize this need for super specialization during accreditation visits. But still, most of the major surgical departments in the country are still doing general surgery as general surgery. The person who is treating rectal cancer today would be the same person that would be treating breast cancer tomorrow. And he would be the person doing thyroid surgery the following week. And he would be the one doing gallbladder surgery the following week. Now, this is also even worse in the private hospitals, where surgeons do operate to make sure that they make ends meet. Now, still, there are a lot of unmet surgical needs in colorectal surgery, and even the quality is not comparable to what is obtained abroad. Kenani George said that ERAS can completely be implemented in Africa with a comparable outcome to the Western countries. So, what is our way forward for ERAS for colorectal surgery in Nigeria? We need more awareness, and we need more specialization. So in this regard, we have to continue the linkages we are doing with our diaspora colleagues. We have to thank the efforts of some of them, like I know Komolife is putting more effort. Dr. Ahmed is also putting more effort to come to Nigeria and disseminate the need for colorectal specialization. More specialist training needs to be done. Even if you are a general surgeon as trained in the West African setting or Nigerian setting, you still need more training to qualify as colorectal surgeon. And then there is need to start implementation of ERAS protocol in the centers that are already colorectal based. Whether with time we would modify the ERAS protocol depend on what we are doing and our observations, and publish scientific data. For example, there is already modification of the ERAS protocol in laparotomy in the low and the middle income countries. Some of the things they have modified there include mandatory retroviral screening, mandatory checklist, which they are not in the one for the Western countries. So we have to do more research on region-based diseases, such as sickle cell patients, and going for colorectal surgeries. We know how dependent these patients are on opioid and others. So what is the recommended pain management system for them? So we have to collaborate with the ERAS to establish our own way forward. So in conclusion, the perioperative care is very important in colorectal surgical patients, and complications can be prevented by thoroughness in periop surgical care through the adherence to the ERAS colorectal guideline. I don't have any disclosure, and the two major references I use for this presentation are the guidelines for perioperative care in elective colorectal surgery, the ERAS 2025, which is published in World Journal of Surgery, June 2025, and the guidelines for perioperative care in elective abdominal and pelvic surgery at primary and secondary hospitals in low and middle income countries. ERAS Society recommendation, also World Journal of Surgery. Thank you so much.
Thank you very much, sir, for this presentation. We're indeed grateful for you taking your time to give us this very interesting talk on ERAS in colorectal surgery in the Nigerian setting. I'd like to hand over to Mr. Emmanuel Gwari to anchor the Q&A session. Thank you, sir.
Thank you very much. Thank you so much for this presentation, and I think it's a timely presentation. Please, I just want to encourage everyone to post their questions on the chat site so that we can have a robust conversation about this. Thank you so much, Dr. Gagarawa, and I think you gave a detailed presentation about ERAS, and I was particularly interested in the area you talked about, the Nigerian experience, about the late presentations and the delayed surgery and all the other factors, the limiting factors there. So my question to you is, knowing the experience we have and the limitations, what are things we can put in place to try and mitigate these limitations to be able to implement this in our setting?
Should I take down the questions or I should continue to talk?
Yeah, if there are other questions, I will present them to you. I was just for us to start while we are waiting for other questions to come in.
Okay. It is very important to look at the ways forward in terms of how to improve the ERAS implementation in Nigeria. I think my last few slides, one of them I mentioned the way forward, and I said more awareness. You understand? It is clear that most general surgeons are not aware of the ERAS recommendation, or they are not willing to implement it. So if we can have colorectal teams in most of the surgical centers, we can come together and create more awareness, create a dedicated team that would painstakingly apply this protocol. From the beginning, it may appear like more task, so people may not be willing to start going towards it. But when the advantages are clearly identified for people, I'm sure they would be willing to join. Now, another thing I said, which was the specialization. We have to encourage at the General Surgeons Forum specialization. There is enough in all the subspecialties. So people should encourage to take one of the 7 ways or even more from the general surgery group. Are you going for pancreatic? Or are you going for hepatobiliary? Are you going for upper GI? Are you going for breast? Are you going for endocrine surgery? Are you going for the lower GI, that is the colorectal? You understand? So we have to encourage people to subspecialize and do more. And we should be referring among ourselves. If we have identified that Dr. Yao is interested in upper GI, let's send upper GI to him, you understand, and encourage him to get more cases. And the same thing for those doing lower GI. Nigeria has become more sophisticated for us to be going from one region to another. So let's all try and talk to ourselves to have more specialization. That would encourage more research. That would encourage more training. And also, I had talked about the specialist colleagues who are abroad. We should link with them to do more training because they would bring a lot of resources for us that we can use. And those who can afford can go abroad also and they expand their knowledge. Now, with that, we should start, however, implementing the little we can at this level. We don't have to implement at all the level of the 23 parameters I outlined, but we can start at some few levels which are very easy. With time also, we should start modifying the ERAS and link up with them to find how, if there is any need to modify it to suit our environment. What would make our presence known to the world is research in this field and in colorectal surgery, you understand, so that our voice could be heard.
Great. Thank you very much. Yeah. Yeah, I just one more question. I can see Professor Fall, Ray of Fall's hand is up there. I was just thinking in terms of the pharmacotherapy, and particularly in the Nigerian setting. I don't know what your advice would be in terms of, leaning away from opiates post-operatively to epidural, or just to, encourage early mobilization and reduce all the other complications that come with it. I don't know what your recommendations are.
The recommendation of ERAS in terms of pain management is as much as possible to reduce use of opiates because of their effect in the cerebrum. They can make patient delirious during the recovery period. And then also because of their respiratory depressant activity. And they can cause post-operative hypoxia with attendant effects. As much as possible, the NSAIDs also, on the other hand, are known to impair wound healing and may predispose to anastomotic leakage. So the techniques of regional blocks, if available, such as trans versus abdominus block, if we have such things, you understand, and also the spinal blocks, especially the lower ones, if we have the anesthetists who know how to do that, we should encourage them. And also with time, the skills will be very prevalent.
Thank you.
The use of patient-administered opioids is now discouraged in ERAS recommendation. You understand? So as much as possible, the use of acetaminophen and then the regional blocks is what is recommended at this time.
Okay. Thank you so much. I have two hands raised here by our esteemed colleagues. Professor Ray Ofo, you have a question, and then Professor Jimmy Coker also has his hand raised. Okay.
Thank you very much, my esteemed senior colleague, Dr. Igware. Thank you, Dr. Yahweh. It's
Hello, we can hear you.
Since the Istanbul training program, that was in 2015, we saw last. Congratulations on all you're doing. My comment is actually mechanical bowel appropriation. I was hoping to find out if you are privy to some research that the outcome was based on a population that has a staple high fiber diet.
Well, we are losing your audio, Professor Ray for maybe what will happen, we'll come back to you. If I just ask Professor Coker to make his comment, because it looks like we've lost signal with Ray for.
Yeah, you can send a message. You can send it as a message, then we read it out, okay?
Yeah.
Thank you very much, esteemed colleagues and chair. I normally give this talk at ERCAD, so I've spent some time reflecting on it, and I just have one or two.
Mic was off.
Hello, can you hear me?
Yes.
Yes.
Okay. Emeka, we'll come back to you. Professor Coker is asking his question now. Yeah.
I was just saying that I will share. There is in one of my readings, I discovered that there is actually an ERAS surgical safety checklist, which incorporates some of the important elements of ERAS into the WHO safety checklist. And I can share that with everybody on the WhatsApp platform because I think it's quite useful. The other thing to say in terms of published data is that there really isn't any from Nigeria, but from Sub-Saharan Africa, we have from South Africa, Kenya, and Egypt. And a lot of the things highlighted are similar, really. And what we found is that a lot of facilities do not adopt all 23 recommendations, but often find it better to pick the most cost-effective of these that will give them the biggest bang for their buck, so to speak. Things like not using an NG tube, early mobilization, multimodal analgesia, early return to regular diets, and discontinuation of IV fluids, as some to mention a few. I know that Professor Ford was going to talk about, well, he was asking his question relating to mechanical bowel preparation. I think that is still the bit that when I saw the 2025 guidelines, I had thought that they would also at least provide some clarity. But I think they're still forging it, because the American American Society for Colon and Rectal Surgeons presented their guidelines on mechanical bowel preparation, and they tended to really now recommend for left-sided colon resections, both mechanical and oral bowel preparation, with strong evidence to that. Yes, I don't think there's any published data from Sub-Saharan Africa on mechanical bowel preparation and colorectal surgery. The closest we probably get will be from Brazil, the Amazonian region of Brazil. They had also put out some papers on that. But I still feel that even with these ERAS, the confusion that relates to mechanical bowel preparation has not really been resolved. What do? I don't give mechanical bowel preparations for right-sided colonic resections, but I do for left-sided colonic resection, particularly if it's quite close to the anus. Thank you.
Thank you so much, Professor Coker.
Thank you
And
very
I
much.
agree more with you. And I think maybe that's something we all should take away. I know there has been this controversy in terms of should we or should we not in terms of bowel preparation. I know there was a time there was a complete swing to the no bowel preparation, but now with increasing data collection, it's becoming apparent that there has not been any significant demonstrable improvement. But from what Professor Coker said, it just makes sense, and that would be my policy too. If you're doing a right-sided, where the ileum is being anastomosed to the colon, it makes sense to not go with that. But for left-sided, because the danger really is if you have a colon that's filled with stool and you anastomose and the patient goes into postoperative ileus, and we know what the colon does, it extracts
Thank you so much. I think what Chief said should be taken, and that is the essence of this discussion. You see, what they highlighted, of course, the mechanical bowel preparation in their guideline was not well addressed. One, they didn't talk about the form of the bowel preparation. They were just emphasizing on the negative aspect of the bowel preparation, such as fluid and electrolyte imbalance, you understand, and then the risk for infection, and then even anastomotic dehiscence. So this is this, but they didn't talk about our own side of the story. People with longer colons, such as Africans that have a high fiber diet, as Professor Ray often was trying to say, but our voice is not being heard because we are not talking. So we have to make our presence known in this group, and as much as possible, tell our experience through our publications so that it will be listened to. Even the checklist for the guideline, their own guideline, the ERAS guideline, they don't have use of checklist in their guideline. But in the ERAS guideline for middle or low and middle income countries, they introduced the checklist. I really don't know why that was so. Maybe because they are relying on a sound communication format with the Western practice more than in the low and the middle income countries. But that is the only time they introduced the ERAS checklist. So these are some of the things. There are many other things that I personally feel that they have not addressed. Intraoperatively, they didn't tell us their own opinion about the dissection methods and the anastomotic methods, you understand? So all these things, maybe later, they would come to this. And for example, are we using cold energy or active energy in terms of dissection, such as low rectal resections and others, stapled versus hand-sewn anastomosis? All these things, they should have made some opinion, but actually that was not mentioned. Still, Chief Mr. Jimmy Cocker is still raising hand. I think he should be allowed to shed more light.
I wanted to, because Ray of all, I think your microphone, is it back on?
Apologies,
Well,
that was a legacy hand.
I actually thought it was off, but it couldn't have been off for all.
No,
from the remarks.
You were coming on and off. It's like the signal was going on and off. That was it.
Oh, really?
Yeah.
Okay. Well, from the comments from Mr. Coker and Dr. Yao, apparently the meat of what I had in mind was grasped. So I rest my case.
Okay, thank you very much. And then we have some questions on the chat site here. And Dr. Irabo has just posted a question and says, thanks, Prof. Yao. I joined a bit after okay. And I want to know if you identified hospitals in Nigeria where ERAS protocol is practiced and compare data from hospitals where ERAS is not adhered to strictly regarding time to oral feeding, time to passage of gas, anastomotic leakage, and ultimately perioperative mortality. Because if you need to convince us that ERAS is the way to go, we need hard data. Over to you, Professor Yao. Or should I read the next question and you can address them together? Yeah, the next question from Dr. Ann Olute says, thank you, sir, for the presentation. Could you elaborate on what you said about no need for NG tube for drainage post-surgery? I thought it was said to be very important in enhancing healing of the bowel. So just two questions before we continue. Over to you, Professor Yao.
The microphone was staggering when you were talking about the question from Dr. Rabo. Really, I didn't get that one. But for the NG2, what is recommended is intraoperative use of NG2 during surgery, particularly the minimally invasive or minimal access surgery. Now, that decompresses the stomach, it drains it, it gives more space for us to do our work. But post-operatively, putting the NG2 is not recommended based on the current guideline, 2025. The argument is it delays early return to oral feeding. And also, it kind of fixes the diaphragm and reduce respiratory excursions, giving more chance for basal atelectasis and respiratory infections. Now, however, there were studies, that said that putting post-operative NG2 reduces the chances of nausea and vomiting. Understand? But such benefits were negated by multiple reinsertions and patient non-satisfaction and discomfort. So the nausea and vomiting could be treated with the drugs, which they recommended, the granisterone, ondansetron, the dexamethasone, and two others which they mentioned. So the pharmacological management of the nausea and vomiting is better when you rely on the NG2. Thank you so much. So maybe if somebody has heard about the doctor.
Can I summarize Dr. Irabo's question? He was just asking if we have comparative data in Nigeria And
honestly, I checked. As I think Chief Mr. Jimmy Coker had answered that. I did my search. There was no publication on ERAS and in Nigeria, but there was one in Africa, which was interesting among others. You understand? But it was done in by Chinese. I was really surprised. You understand? And they were detailed, and it was in Journal of Clinical Surgery. They said, based on, I don't know which hospital they use, from their own description, it's like they use some hospital in West Africa, in East Africa, and South Africa. Maybe their methodology was not clear. Was it meta-analysis they did, or was it surgery, a surgical research perspective that was done in such multi-center studies? So maybe we really need to go and look further. But in Nigeria, based on my own search, I didn't see any study on ERAS and colorectal surgery.
Can I come in here, please? Professor Yao?
Yes. Yes.
I didn't expect any published data from Nigeria. All I thought you would do was maybe contact 2 or 3 of your colleagues. I believe you adhere to the ERAS protocol wherever you are practicing. So all you needed was to get, like we have members list on this forum, that I could ask, do you use ERAS, and what are your own results like? All I need to know is that, is this thing just theoretical? Because now you've given us a lot of theory. Now, Nigerian experience, that is what your title says. Colorectal surgery, ERAS, colorectal surgery. I haven't heard anything about Nigerian experience. That's why I thought, do you ask anybody? You could have asked any of our colleagues here, do you practice this thing here? What are your results like? I'd like to know. I'm going to give a lecture on this thing next month. Please, could you just give me an idea? That's all I'm asking. Not that you should go online and start to search. Of course, if anybody wants to publish a paper on ERAS in Nigeria, it probably won't get published because everybody will say, okay, like Mr. Coker said, some of these things are on the WHO checklist. So you now say WHO checklist in colorectal surgery in Nigeria. Who's going to publish that? You won't find that. It has to be interactions between colleagues. Thank you.
Okay, thank you so much, sir.
Thank you very much. Thanks, Dr. Rabo. Point taken. I'm conscious of the time now, and there are a few more questions here. I'll just go through them, and then I will just ask Professor Yao to make comments on them. And there's a question from Dr. Makama who says, what is ERA's recommendation for bowel prep in emergency situation, since colonic washout is frowned at? And the other question says, are there any modifications to the ERAS protocol for the pediatric age group? Professor Yao, are you still? Oh, you're muted. Professor Yao, can you hear us?
Professor Yao, can you hear us, sir? I've asked you to unmute yourself, sir.
Yes, I can hear you. I don't know how I got muted. The guideline for 2025 did not include emergency surgery. It was just on elective major surgery. Now, the pediatric recommendation, actually, I didn't review that one, but maybe it was given as maybe as an ERAS pediatric colorectal surgery, but I didn't see it, honestly. So the one I relied upon were for adult surgeries, and they were elective surgeries.
Okay, thank you. And there's another question from one of our esteemed anesthetists who is joining us tonight, Dr. Omolola. It says, he's just, again, asking questions in the same vein as Dr. Erabo. And now he's asking about if there has been any data with regards to anesthesia for these patients, the outcomes. And secondly, has there been efforts to collaborate with anesthetists on achieving progress in ensuring ERAS guidelines locally?
Well, it's one of the things I said during the lectures, that it has to be multidisciplinary. And even as I was saying, I said in the team that wrote the current guidelines, there were 5 anesthetists. And I recommended that locally we should form teams with people who are interested, to institutionalize these protocols nationwide. I think the way forward should be to get some few centers to start it and to publicize it and encourage other centers to agree to be mentored. So Chief Rabo has already said about that hindsight of not making personal contact maybe during the descent. I relied strongly on the descent on the online searches, which did not show either surgeons or anesthetists publishing data on ERAS practice in Nigeria.
Thank you. Thank you very much. I think for the sake of time, there's just one more question. I don't want us to go without attending to the questions on the chat site. And this question is from Dr. Arnold Lute again. And she said, the post-op early mobilization within 6 hours, does this apply to open surgery too? And then she asked another question. It says, you seem to have suggested that intraoperative blood transfusion for colorectal surgery should be discouraged. How long post-operatively would be a good or relatively safer period to transfuse the patient? So in terms of early mobilization, I know she's talking about the open surgery. Does this apply to them too? And then in terms of blood transfusion in these patients, when is it safe to transfuse them?
The ERAS recommendation for access is minimal access surgery more than open surgery. But what they said was for colorectal, for colonic surgery, within the first 6 hours, you understand, patients should be encouraged to move. There was a recommendation in one of their publications which says within 30 minutes of recovery from anesthesia, and they frown at that. So now what they are sticking to is within the first 6 hours, patients should be encouraged to move and continue moving as tolerated. Because before, there was another recommendation that says patients should be encouraged to target 6 hours in 24 hours. But now they said that one has not been found to have any good effect or good outcome or reduction of complications. So they are saying now that the first 6 hours, patients should be encouraged to sit up, you understand, and move as tolerated. They didn't give any time-bound thing. Now, I think whether we have done, what do you call it, open surgery or minimal access surgery, the principle is the patient tolerance. It should be early enough that the patient is not put into increased post-operative pain, but how much he does should be tolerated. It wasn't clearly spelled out. Okay, so this is about the movement. The other question is about what?
Yeah, the other question is about blood transfusion.
Okay.
You did indicate that intraoperative
blood transfusion for colorectal surgery, especially for malignant colorectal surgery, is associated with poor outcome, both disease-free survival and total survival of the patient. We have to consider that the transfusion they are talking about is intra-op. That's why they did whatever they could to say that patients should be optimized before surgery. And during that optimization, the recommended thing is parenteral iron, which should be given for a period of 1 month. But if for a reason the patient has to go to theater early, erythropoietin 300 international units per kg should be given. Now, this is their recommendation. Post-operatively, to understand, it wasn't said whether there is a risk, definitive risk for the patient poor outcome. So this is what I got. But if there is somebody who has gotten any information, we can share it in the group in relation to post-operative blood transfusion.
Yeah, for my interest, I was just wondering how much the erythropoietin would cost in administering that to a patient in Nigeria. I don't know if we have any information on that.
Don't know the cost. Anybody with idea about the cost?
Okay, maybe if we can get that, if we can just post some of these comments.
Yes, I know it is available, but I don't know the cost, honestly. Okay, but I know it is available.
Yeah, great. Thank you so much. I really want to appreciate you for taking time to delve into this topic. And I think it's a topic that we are.
I managed one patient that was buying erythropoietin. I think it's about 48,000 a vial, just one vial.
So it's not cheap. Yeah. Okay, thank you very much for that information. Yeah. So I just want to thank Dr. Gagarawa for tonight's presentation, and I thank everyone for the very robust conversation we've had. And please, if there are other comments, questions, if they can be posted on the WhatsApp forum, answers can be provided for this, and we can continue this conversation thereafter. But time is always our enemy on this platform. So I'll be handing back to Mr. President to finalize the meeting. Thank you so much.
Thank you so much, sir, for anchoring these very interesting and robust conversations. Again, we are very grateful for our teachers and our elders, for everyone who has contributed and asked questions. I'm sure we've learned one or two things in here, and we've gone out with some food for thought. As promised, and the recordings of this meeting will be available online, and Steve has also agreed to share his slides, and we look forward to the other documents that will be shared on the platform, especially checklists from Mr. Jimmy Coker. Again, there are no announcements from us at this moment now, but information will pass across to us on the WhatsApp group in due course in the coming days regarding some new developments. I would like to thank us once again for attending this meeting, and I wish us all a good night's rest and a happy week ahead. Thank you.
Thank you.
Thank you.